Good morning, everyone. Thank you so much for joining to this session. We're excited to have you. We're excited to have our educator who's going to share more than 16 years of experience working at Montefiore Medical Center in New York City in the Bronx. So Marissa Gayle has a lot of experience that is willing and very eager to share with us today. We're excited to having her and we'd like to start the session.
Hi, good morning, everybody. I want to make sure you can hear me. Let me put my volume up and welcome. My talk today is simulation principles. We will start with a Zoom poll. Hold on. One second. I want to advance my screen. There we go. Could somebody launch the poll? And the poll starts out with just like a introduction question. What method of simulation does your clinic use? So I'll give us like 40 seconds to answer the question. Let's see what the result is. Okay, so I'm going to end the poll. So from the results I see, the vast majority of us are doing CT simulations only. Only about 3% is still using a conventional sim. So basically, everybody's using a conventional sim. So that's what we're going to focus today with this talk. So a couple of things we're going to go over today. What happens at a simulation? What do I need to know about CT simulations for IMRT? And patient's positioning, what makes a good setup? Those are the three things that are going to be key to any successful setup and therefore will translate into successful treatment down the line, which will make it very straightforward, streamlined, and we'll get better reproducibility. So a couple of things. We want to determine the patient position. We want to gather information for treatment planning. We're going to document everything in patient education. So a couple of things. Determination of patient position should be our main objective. What area are we going to treat? Are we going to have tattoos, marks? What kind of immobilization device will we use? Are we going to be using an alpha cradle, a vac lock, an aquaplast mask, or maybe just a knee wedge? What are we going to use? We got to document everything because we may not be the therapists that will be treating. There may be other therapists that need to know exactly what we did in case we're not there. And patient education, which could be twofold: to explain what the patient's going to expect at the time of the sim, kind of to give them a run through of what to expect, and also what to expect during treatment. Important factors are going to be beam access to the target site, again, reproducibility of the physician, and collision clearance. Like I mentioned this at this point because we need to think about all these things before we start the sim. Like exactly where are we treating? Head and neck, pelvis. And if we're treating those sites, how is the patient going to be on the table? Do they have other issues? Are they like, can they walk? Can they not walk? Are they in pain? And then also, when we make these immobilizations device, once we put them on the treatment table, depending on the field arrangement that physics and the dosimetrists come up with, are we going to have any collisions? So here we have some sites to consider. So like I mentioned before, the first one is like head and neck. You see the patient's pretty like center of the table. So this is pretty straightforward. But whenever we're treating maybe a body position that's either extremely anterior or posterior or anything that's lateral, we want to make sure that whatever we're creating when they're on the treatment machine, that we will not have any type of clearance issues. Like I said, the position must be reproducible. So the first picture we see people with a shirt on. We will ask the patient to please change and put a gown on. We want to have as less things in the way that would add for bulk. Also make sure that if we're treating something head and neck, that they're not having earrings in or any type of like jewelry that might be in the field. Making sure if we're doing like a pelvis, that they do remove like their pants or maybe even underwear. We'll make sure that they're covered to maintain like modesty, but we want to get as much clothing and bulk out of the way. Even with inpatients, if they come down with a lot of sheets and chucks underneath them, we try to take as many things out so the patient is as flat as possible so that we can ensure that the position can be duplicated. So again, these are diagrams showing that if the patient, let's say if their arms are too wide, you could get a collision here when you're setting up the patient in the treatment room. So you want everything to kind of be as center as possible. Also, if you have any questions, to definitely bring in the physicists and the dosimetrists during the simulation process to make sure that everybody's kind of on board and making sure that whatever immobilization device that you're creating will be workable also in the treatment room. So a couple of us were still using a conventional simulator. A conventional simulation is used only for 2D and 3D forward treatment planning technique. MRT treatment planning cannot be done with a conventional sim. The tumor is located and it's assumed relative to bony anatomy. I just wanted to give a little bit of background information on conventional sims, since a couple of people are still using this technique. A conventional simulation machine is capable of the same mechanical movements as a treatment unit. The images obtained from these machines are essentially two-dimensional with the facility to acquire a limited number of axial slices to provide patient contours and tissue density information. Like I said before, it's forward treatment planning, and which means that the treatment planning mostly depends on the geometric relationship between the tumor and the nearby sensitive structures. With a conventional sim, we're unable to do an IMRT treatment plan, and the beam angles, field size is all determined at the time of sim. Generally during conventional sim, we will use a diagnostic X-ray tube, which duplicates the radiation treatment unit in terms of like the way it moves, geometric, mechanical, and optical properties. The main function of the simulator is to display the treatment fields so that the target volume may be accurately encompassed. So we have a picture here of the conventional sim. As I said before, it's going to determine like the gantry angles, the collimator angles, field size, distance, separation, and contours, which are done with wires. And like was said before, it takes a 2D image. And so I have an example here of So over here, I have an example of a 2D image. Is from a head and neck. The gantry is at 270, and we can see how they drew out like a block. So this is with a conventional sim. Another thing to take into account when we're doing any kind of simulation, be it 2D or with a conventional sim and with a CT sim, we need to mark the skin. So what's the purpose of skin marks? To mark the location of the isocenter for positioning, and we need either 3 points of data for positioning. We also could do 2 points, which will be biangulation, 3 points would be triangulation. And we also want to put the tattoos in someplace that's a stable position. So stable meaning you wouldn't want to necessarily, if you're treating a lung case, and let's say it's a patient, is a female, and she has very pendulous breasts, you would try not to put the isocenter like on breast tissue. You would probably look for something, a spot either above where the iso is or below, and then have a shift that physics will give you. They'll tell you to shift to an iso, as an example. So, and then you want to use additional marks. So I have a diagram. So this is a diagram that shows the 3-point alignment. So you definitely would have 1 anterior if the patient is supine, and then 2 on the laterals, which will be your leveling mark, and then will give you left, right. Then we have biangulation, which we will use at times for like breast setups and maybe extremities, which uses a 2-point system. So you use the tabletop as the depth, and you will, roll the patient to that where the lateral tattoo is, and then use the left to right. And we have a diagram that shows that. Then once you kind of have an isocenter picked out, you need to mark it so that when the patient gets on the treatment machine, they know where the marks are. So I have some pictures here showing, like our site, we use an 18 gauge needle and single use tattoo and ink, and which creates a tattoo on the patient's skin that can be seen by all the therapists on the treatment unit. We have patients who, for religious reasons, do not want tattoos, or we treat a lot of pediatric cases where we will use stickers, we will use paint marker, Tegaderm to mark where we're treating, and then every other day we will definitely remark the site so that we don't lose the marks. Another thing to take into account is when we deal with reproducibility is that for every CT simulation, physics has to come in and give a set of instructions on how to do warm up and QA the machine. And part of the QA process is making sure that the lasers are accurately aligned. And we have an image here of the cube and how the lasers are used in alignment with setting up the patients each and every day to the tattoo. So if your lasers are off and you try to set your patient up with lasers that are off, your patient may also be off. So every facility has their own policies and procedures. So your facility may have different requirements before starting treatment. So you need a consent. You need to make sure that the patient wants to get this done. That's number one, that the patient has to be in agreement. Also, another important thing is that there's a pathology report so that we know what we're treating and that the patient is a candidate for treatment. And then we need to know what the doctor would like to do. So the doctor has already discussed with the patient that they have a diagnosis, what their diagnosis is. The patient now has agreed to treatment. Now the doctor will give us like a checklist telling us what to do next, letting us know like what he would like us to do. So I have a diagram of that also, which is like a checklist. It's going to give us some ideas of what we're doing. So the first part of it, I don't know if you can see it, you may have to like zoom in if you're on a camera. It will let us know like my facility, I work at Montefiore. It's very large. So we have different sites. You have to pick the site. But then we have to pick the site on the patient that we're treating. We're going to pick, if it's like a breast, let's use that for example, right or left. So we know which body part we are actually treating. If it's a woman of childbearing age, they need to have a pregnancy test and know that they're not pregnant. Also, we need whatever blood work needs to be done in case we have to give IV contrast. and dental clearance. We'll use that especially for patients that are head and neck. Then the second portion of it will tell us what he would like us to do. Like what kinds of, if the patient needs bolus, if the patient needs to have a full bladder versus an empty bladder. If we need to, the patient had previous treatment, are we reusing tattoos that they already had placed? Then the next page will be what kind of treatment is it? Iron meat, 3D, 2D? Do they need a mask? Do they need a vac lock? Are they going to be on a breastboard? It's going to give us everything we need to know, and it's a checklist so that when we get to the patient, we bring the patient to our CT, we have a game plan and we know exactly what we're doing and there's no guesswork involved. And then, like I said before, everything is documentation. So we're going to write down everything that we did. So like I said before, everything is in the documentation, right? So we need to take pictures. We need to document everything that we did. And we need to create setup notes. So like I said, the therapists that are now will be treating this patient have the game plan. They know exactly what you did in the CT sim so that they can reproduce it each and every day to ensure that the patient is getting the most accurate treatment possible. So part of that is we have setup notes and photos. We take pictures of everything. We take pictures of the tattoos. We take pictures of the positioning that the patient is in. We take pictures of the device we use. The device is clearly labeled with the patient's name, date of birth, date of sim, whatever other immobilization device is, everything is documented. Also, we will document, for example, if it's a patient is a prostate patient, we like to make sure that our prostate patients have a full bladder. We will document how much water they drank, how long they waited before we started that scan, so that we will have the pretty much the same bladder fill every day for treatment. We will also make note of any kind of separation, distance, field size, collimator. Some of that information is also on the plan, but we will make note of everything. Also, we'll put special notes. My site is in the hospital. So we get a mixture of outpatients, inpatients, patients that are coming from nursing homes. So we'll make notes on the chart, such as patient is unable to walk, so that we know that the patient may need to be lifted out of a wheelchair. We'll make a note that patient may need assistance in changing. So if they come with an aide, to let the aide know also what the patient needs to change into, like, oh, the patient has to change into a gown and they need to take everything off from the waist up. We've had patients that were like visually impaired, so they will need like someone to guide them back to the changing room and walk around. Well, we will make notes of everything. Also, some patients are claustrophobic, so they may need to take something, to take the edge off. Our facility prescribes Ativan. We'll need to tell, before you come in, you need to take your pill an hour, half hour, 20 minutes before your treatment time. So we'll notate everything on our charts.
Do you think we have a moment for a question?
Sure, yes. Any questions? I'm so sorry.
You are good. So we basically, I think we have covered a fair amount of ground, very important concepts, very useful, very practical concepts. Along those lines, one of the questions from one of the participants is whether you could share those documents with the group, because they believe it's a good way to document the implementation of simulation and try to standardize that method within their centers.
Yes, I do have those documents. Actually, I have them here. What I can do is I can scan them, and then I don't know who to email, but I'll definitely email it. I have it here at home.
You can
So
email
I
it
could,
to me or to
okay,
our RCC email, and we'll share it with the participants. Thank you
okay,
so much.
I'll make note of that and I will do that after this lecture is done, since I have it here.
Very good. And I believe Ephraim has a question for you. So I'm asking
Okay,
him to.
Hello. Yes,
hello.
I have. Yes, I have a question. You said that you check for patient if they are pregnant or not. So
Yes.
in this case, you have the patient is pregnant. What do you advise? Will you proceed with the radiotherapy or need to wait until delivery is when can start the treatment? I just want to be clear on that.
A couple of things. So I'm gonna take it from the top. We do pregnancy tests to everybody that's childbearing age. That for us will be from the age about 12 to 55, part one. Part two is before they start treatment, they have to sign a waiver saying what the risk would be if they do become pregnant. That's part two. On that waiver, we will stipulate, what kind of birth control you should use so that you do not get pregnant. So patients, like I've only had this happen maybe one time in my career, depending on what it is and where they were being treated and the staging it was. So a lady I was a student, so this is a long time ago. She was pregnant and was diagnosed with something very advanced. They created like a blocking mechanism because she was so far along and she was able to get treated. She was not treated anywhere near her abdomen. We were treating something in her brain. So that was number one. Number two, some patients have either found out and have chosen to end that pregnancy, or some people have waited to the end. It just depends on diagnosis, staging, and choices that the patient then had to make for themselves and what they felt that would be best. I hope I was able to answer your question.
Yes, thank you.
You're welcome. Do I have any other questions?
I don't believe so.
Okay. So we'll continue on with patient education. And actually that question does fall in line with patient education. Sorry, somebody had a question? Okay.
No.
So, and part of that is educating the patient to, somebody had a question?
I don't think
I keep hearing
so. Let me
feedback.
mute
Okay.
everyone because it's
That I dropped a question in the chat box
Mhm.
about dental clearance. What does this mean?
All right, the moderator will go through the chat box and I will definitely answer your question. So like I said, all this does fall within patient education, right? So here we go. We have to explain the role of treatment and the purpose of immobilization and what it means, because this is the first time a lot of our patients are even interacting with radiation therapy. A lot of patients never even heard of this department. They do not know what it entails. They think it's something from like Star Trek, sci-fi sometimes. This is what happens. So our job is to educate. So we have to explain why we're making this immobilization device, why they may not be as comfortable, why they have to drink water to have a full bladder, why when they come in, they may need to have an empty rectum. We have to explain all those things to them. But also when we are creating these immobilization devices, you want them to be as comfortable, and I use that loosely, as possible. Yes, the table is hard. And your positioning may be a little awkward, but we do not want to be causing greater pain, and have to be a position that they're going to be willing and able to hold still for about 30 minutes. So we need to check that they are comfortable so they don't feel the need to constantly adjust positions. The instructions for the first treatment. So a couple of things. I'm in a larger department, so this depends on the size of your department. Do you have a big department? Do you have a small department? Some of these things are, relative. So a couple of little things like, where do I go to check in? How do I find the department? Once I get to the department, what is the procedure? If I'm a prostate patient, should I come 30 minutes earlier than my appointment time? Start drinking so that when my appointment time at 9:30, I'm ready to go and I can be in and out in under 20 minutes. Where is the changing room? Do I need to have any preps either before the CT simulation? So some of our CT sims, we ask that the patient be NPO, not eat 4 hours before because they'll be giving contrast. Or we want them to have an empty stomach because we're doing like a liver study and we don't want anything in their stomach that may, push the liver out of the way. Or we may ask that they do a bowel prep, that their bowel is completely empty, especially for our patients. So we're going to either call you the night before to tell you what some of these instructions are, or we will give you these instructions once you arrive at the clinic. So I have another poll. Which of the following is not a desirable quality of an effective and useful immobilization device based on the information I've given you so far. So let's see what you guys get. Majority of you answered the correct answer. Requires additional setup time. And that's key, requiring additional setup time. I've worked, like I said, in a large hospital in a very big city. I'm from New York City and I work in one of the boroughs in the Bronx. We're very busy, our site. So anything that's requiring additional setup time is going to throw our schedule off. We start treating from 7 a.m. and we go to 6:30 p.m. We try to make sure that we're done by 6:30. If not, we're staying later. And, one day staying later is not bad, but on a consistent basis, meaning we do not want that. That's for us. Also, we don't want to make the patient be there any longer than they have to. A lot of our patients work. Many of our patients depend on family members who work, who bring them and have a set time constraint. So also patients don't want to be in a position with your arms up, bladder full for an extended period of time that they don't necessarily have to. So that requiring additional setup time is key. Now, we're going to talk a little bit more about a CT simulation, how to do a CT scan, and the power of protocols. So this is a CT sim. This is not the one we have in our department. We have a Siemens Healthineers, but this is generally what a CT scan looks like. I believe this is a picture of our old scan that we had. Couple of pieces of information about a CT scan. A CT simulation uses a CT scanner to localize the treatment fields. The treatment couch lasers are used to define the scan and treatment isocenter. The software provides external contours, target volumes, and critical structures, portal displays, and placement and review of treatment plans. Simulation films are replaced with digitally reconstructed radiographs, otherwise known as DRR. So, and an example of that would be, okay. Visualizing patient anatomy for treatment planning. Inverse treatment planning we discussed. So an inverse treatment planning can be used for any treatment technique. So now with a CT sim, you could do whatever you desire. 2D, 3D, IMRT, VMED, SBRT, SRS. The tumor target location is based on a CT scan, Many target volumes are based on soft tissue and vessels rather than the bony anatomy. More precise targets and greater conformality results in better tumor control and less toxicity to normal tissue. Also, this can be called, like I said, inverse treatment planning as discussed. And then this is also, technology has made it that this would be a better way to create a treatment plan. Since beam angles, field size are determined later thanks to the inverse treatment planning, the CT simulation process can be shorter. However, it's very important to do a high quality CT scan. And before we start the CT simulation process, we need to have, like I said before, also a pathology report, a signed consent from the patient, and also our physicians have submitted orders telling us exactly what they would like for us to do. And again, we're going to do the same things that we did before. We're going to make sure that the patient is educated. And some of the education starts with, in our department, like I said, I'm in a large hospital. So some of these things that I'm saying, the therapist may have to do, but at my job, we do this in conjunction with other people that are part of our therapy team. So for one thing, we have the nurses sometimes also educate and explain to our patients what to expect during the CT simulation. Depending, like I said, on the site, the nurses will also place the IV line and let the patient know about the contract. We will also call patients and tell them from the night before their scan, you need to not eat anything for 4 hours. We let patients know, for example, our GYN patients, that they may have to have a Foley catheter inserted. We will let our prostate patients know, hey, by the way, you need to do a bowel prep before you come in for your CT simulation and have a light breakfast that day. So the main part of all this is patient positioning is super duper important. So I'm going to go over a couple of slides that's going to show you a couple of things that will help in the patient positioning process. So here we have a picture of a mask being made, but a couple of things I want to talk about before we get to that. The patient's going to meet you. You're going to introduce yourself. I'll be like, hi, my name is Marissa. I'm your radiation therapist. And I'm going to explain exactly what we're going to do that day. So if we're making a mask, I'll let the patient know, hey, we'll be making a mask. I'll let them know that it's a thermoplastic mask. And when it's touching their face, it may be warm, but it will cool quickly. I'll let the patient know it's important to try not to move. I'll let them know that they'll get tattoos and they'll get pictures. I try to give them a brief overview of what to expect. I let the patient know that we're allotted 60 minutes and, we may take 60 minutes or we may take less time, but we're going to use the 60 minutes. I make sure that whatever area we're treating, that the patient has changed and I have full access to it. And like I said, depending on the site, if this patient is a head and neck, I'll make sure they do not have dentures. If they're wearing earrings, nose rings, wigs, all those things must come off. If they have long hair, locks, extensions, I try to pull their hair into a ponytail at the top and then make a hole in the thermoplastic mask so the hair can fall through. So that will add for reproducibility of the setup. Like I said, some patients may have to get IV contrast. We will let them know about that. If it's not IV contrast, it may be oral contrast. So I'll give them the solution to drink. Some patients, like the GYN patients, may need a Foley catheter. And then some of our prostate patients may need to be given water to drink. Whatever it is, I'm going to explain it to them at the beginning before they've changed, so they kind of have an idea of what needs to be done.
Hi, Marissa. Do we have time for a
Yes.
couple of questions that have come through?
Sure.
So the one that more related to setup and positioning is the one of the later ones, and it has to do with the simulation procedure itself. And question is, who is supposed to administer the contrast? The radiotherapist, the nurse, or the physician?
It depends on the rules of your state, your locality, and your country. So for me, I live in New York and I'm in New York City. So for us, there's very strict rules of people's job positioning and not going out of your title. So for where I work, the nurses are the ones that administer the IV contrast. There are some facilities where therapists become licensed and they then can, but where I work, it's the nurses that do it only.
I think that's an excellent point. It depends on local regulations, including the hospital, the state, and the country. So very, very good question.
Yes.
Yeah,
whatever the rules are, those are the rules you follow.
And I think there were at least 2 or 3 questions related to whether you could expand more about the concept of inverse planning and how that applies to being used in 2D, 3D, and in general, what do you mean by inverse planning?
Meaning that they do the scan, they do the CT scan, and then they plan. Then they try to figure out what the beam arrangements are. They will then look at it kind of after the fact. Whereas when you had a conventional SIM, it was forward planning. You knew exactly, I'm treating a breast patient. These are the angles that we're going to treat at. We did everything before. So that's the main difference between inverse and forward planning. Most CT SIMs departments and physicists are going to be inverse planning. You're going to do the SIM, then they're going to create the field arrangements. Then they're going to figure out, oh, we're going to run a couple different plans, and based on the different plans that they run, they will look to see, you know, what's the best dose distribution, what's getting covered, what critical structures are there that has a tissue tolerance. They're going to figure all these things out, you know, for example, as your doctor, and then they're going to come up with that plan, and whatever is the best plan, that's the plan they're going to use. Does that answer the question, or?
I think people still would like to get a better difference between forward planning, inverse planning, and how to apply it to, let's say, a 2D treatment.
Well, when you have a conventional SIM, you can only do a 2D or 3D treatment, meaning you're going to do something that's APPA or simple post, like oblique fields, but you know what you're treating. For example, if you're treating like a spine, you know, I'm treating T8, for example, I'm going to treat, a vertebral body above, a vertebral body below. You take an image, you put the field on, you know that's what you're treating. So that will be forward planning. You start at the beginning, you know what you want, that's what you're going to do. Whereas with inverse planning, let's say you're treating the same spine, but now you're going to say, maybe we could do an SBRT plan, and instead of having to do the 2 vertebral bodies, we'll just have to do this one. We're going to create some fancy field arrangements. We're going to see how much dose, maybe we could give more dose posteriorly at different angles. Maybe we'll do an arc. The options are numerous. I'm not a physicist, so I can't talk about treatment planning, but I can tell you that will be the difference. Does that answer it a little bit better?
It does to me. So we'll let it sink for a few more moments to people.
Okay.
And more questions came up, because that was kind of the biggest question has been coming through, is that how can they differentiate between inverse and forward planning, and the implications for the different options they have to treat with different modalities, 2D, 3D, IMRT, and so forth. So I think we have explained enough that concept. I'm just going to wait for their feedback. And before we move on, another very practical question, and it has to do with if there is any guidelines to follow how to you may use contrast needing for specific cases, how much is the volume, and whether or not you could share that.
In the United States, everything is pre-done for us. So that's depending on the doc. So for example, the majority of our head and neck cases, he will use contrast because he wants to highlight all those lymph nodes and critical structures that are in the head. And then the nurses will make sure that their creatinine level is within range, that their kidneys can now process the contrast when we're done. So that's really doctor dependent. I believe the bottle is 50 milliliters. I do have a slide in here. Going through the slides, we may see it. I'm basing this on my memory because, and we have a machine that automatically like dispenses it for us based on the structure, based on the part of the body. It tells us when we need to administer it. So that's for the IV contrast. Was there another contrast the individual had a question about?
No, I think it was mostly about that, the timing and how to deploy IV contrast. I think we can continue with the lecture.
Okay. So the next slide is clearance. I know I spoke to it before, but you want to make sure that once you create this immobilization device, that it will clear the machine. And so we've had it on occasion, maybe a patient's really, really tall and their arms go out very wide instead of straight back, that if it's something in the upper lung areas, when we try to clear it with like any kind of rapid arc treatment, we may get very close to their elbows or even to the molds. So we want to make sure that whatever we're creating in the sim will also clear on the treatment unit. So a couple of things. So we discussed, taking a scan. We've discussed making sure we've marked the ISO center. So we're at the point in the sim where we've made a mobilization device. We've figured out where the ISO center is going to be, and we've marked it with a Sharpie. So we kind of know where the lasers are aligning. Now we have to do the final scan. And the only way that the planners and the physicists are going to know where we marked with our Sharpie is by putting BBs or any type of reference point that will highlight on the CT scan. So we can see here, we have skin marks are the same, and we have 2 or 3 points called the CT reference marks. So you can see here where on the scan, they have the little BBs. So we will use this to mark where the doctor has placed to be the ISO center. Also, we can use wire, especially with our breast patients, we may wire the scar. And this is also will show up on our CT scan so they know where the breast tissue ends. So we'll see here, they mark the top, midline, bottom, lateral, and then this one is marking the scar. So that when they're planning, they know exactly where the scar is and where the breast tissue starts and ends. Okay, here is the scan about the IV contrast that we're asking about. Sorry. So this is the oral contrast that we give, that's the gastrographin. This we use also for our GYN doctor likes to insert a little bit of the cystographin into the water that he will push into the bladder for the full and empty. We use Visipake. It's 350 milligrams. I said 50, I was off. With easy pay, so these are some of the different types of contrast is used to visualize the soft tissue. Also, so let's go over the steps we've done so far. So now we've made an immobilization device. We have made sure that whatever contrast, some contrast medium has been given, be it oral contrast. We'll start with that one. We've made sure that the patient is comfortable. Now we want to take a scout. We want to make sure that the patient is straight, or straight for them, because we've had some patients that have like a scoliosis, so they're naturally curved. This way, this is reproducible. It's easier to set up every day, make sure that the person's nice and straight, than to make sure that they were crooked or in a position that's kind of like topsy-turvy, so to speak. So on a scout, you use it to select the range. So on this scout, we're probably doing a lung. So we encompass the apex and to the bottom. We should have also had the diaphragm in there. There's also an opportunity to check to make adjustments prior to the final scan. So if we notice that the patient's a little bit crooked, this is our chance to kind of like fix it. Straight is easier to reproduce than crooked. And then we want to make sure there's not any other artifact in the way. Sometimes patients have a belt that we didn't see, or a piece of jewelry that was dangling that we couldn't visualize. So this is a good chance, if we catch it, to remove it at this time before we do the final scan. So now that you've gotten your scout, you know that your patient's nice and straight. The next thing is, well, how much should I scan? So depending on the body part, these are some of guidelines I like to use. So if the patient's anywhere from the head and neck, we like to scan from the top of the head to the carina, or even below the diaphragm. It really depends where in here, but we'll go from basically top of head to the below the diaphragm. That's for our head and neck. Anything within the thorax, we want to do from the clavicles to past the diaphragm. Our GYN cases, we want to do from the periaortic to mid-femur. And then prostates, we'll do from L4 to mid-femur. So now you're ready to scan. You have everything set. You've made the immobilization device. You have your BBs on. The ISO is marked. You know the range that you want to scan in. Everything is set to go. You set up the lasers in the room to the BBs, and you have advanced the patient to where they need to be in the room. You have now stepped outside. Now you're in the control room where the patient's in the room by themselves. So I have a video of a scan. Let me see if I pull these. My video is not playing. Well, actually, it's a couple slides back in. So we'll come back to a video that I have of an actual scan. We'll just hold that thought for a second. So you've scanned the patient at this point and everything looks good. So now we're back to documentation. I know I've been repeating myself, but some of this is very important. So same as before, you're going to document everything. So you're going to document the name of the patient, their date of birth, the site, the date that you did the simulation. You will take setup notes, triangulate at ISO, treat at ISO, or triangulate at inferior marks, shift to ISO. You're going to notate whatever it is. Biangulate the patient, tabletop 20, notate everything. It'll make it easier and make sure it's clear and concise and it's easy to follow. So like I said here, for treatment planning, we will again document. You're gonna need, so once you take a scan, let me go a step back, I'm sorry. Once you've scanned the patient and you've scanned everything, once you have scanned the patient, you've notated everything, you've documented everything, and you've done the CT sim, the next step is sometimes you take one scan, sometimes you take 2 scans, maybe one scan was just, a regular scan and another scan has contrast on it. Or one scan is GYN, the patient has an empty bladder. The second scan, the patient has a full bladder. You need to, like I said, we got to document everything. So when you're sending these scans over to the dosimetrist or into the importing it into the treatment planning software, we need to notate everything. We need to say what the scan was, like, GYN full bladder, GYN empty bladder, or free breathing, breath hold, respiratory gating, or whatever the scan was, you need to notate it so that when the individuals in the planning, the dosimetrists and the physicists are making these plans, they know exactly what scan that they're looking at. Also, depending on what we are treating and the technique, we need to discuss the slice thickness. So if for us, for example, if it's SRS or SBRT, we do 1 millimeter thickness scans. Everything else is 2. Then the area we're treating, make sure that we have the complete field of view. And that everything is shown in the field of view and that we have the BBs, everything that they need to see is on that scan and they're able to plan off of that scan. Again, I have another CT simulation worksheet I will share with you, which goes over everything for the setup. So the name of the patient, where we're treating, their date of birth, what is it? Is it a rescan? Is it a cone down? Respiratory gating, they would give oral contrast, what the patient's setup is, head and neck, shoulder mask, windboard, prone breast, supine breast, whatever it is listed, and then you just check it off. Now, before the patient leaves, because I've done this before, make sure you have everything because you want to make sure, and if you forget a step, it's okay, you bring them back and you do that step while you still have them instead of making they get home and then you're like, oh no, I gotta call them back. I mean, things happen. Sometimes there's some kind of miscommunication, but we want to ensure that we have everything before the patient leaves. So a couple of things that I think are important to know is after you create the immobilization device, you want to make sure everything is labeled for the patient. We also want to make sure that all the scans are in there, that the scans look good, that we made sure that the patient was straight, that they were comfortable, that they know what they need to do when they come back into the department. Do they know when they're coming back into the department? Have we discussed what time their appointment is? We want to make sure all these things are done. Did we, when we did that scan, did we make sure we put the BBs on it that the dosimetrist can see? So we're going to scroll through our scan to make sure whatever is marked. If there's anything complicated, was physics there to review what we did and say, yeah, this is good, this will work, we can plan off of this. We want to make sure that we took photos of all the sites. especially the patient's
خلصت
multiple sites.
تسهل
Like,
لك شغلي
we
وابجدي.
documented everything. So we're going to talk a little bit about protocols, some things to make our job a little bit easier. And I saw this firsthand. So last year, or maybe 2 years ago, we got a new CT simulator. And it was very interesting for me to see how we then created new protocols for every part of the body. So that makes it easier that when you scan each patient, you're not having to try and figure it out every single day. So a CD protocol is a set of parameters that specifically to specify specific exam and contrast delivery requirements. The physics team can preset protocols for each anatomical site, head, chest, abdomen, pelvis, extremities. And since we do scan children, we have protocols for image gently for our pediatric cases. Once these protocols were then set into the CT sim, it's very easy for now the radiation therapist, because if I'm going to do a head and neck scan, I click on the head and neck protocol and then I proceed. And then with these protocols, they will have the slice thickness, scan settings, contrast settings. Everything will be then set for anatomical site and disease. You just have to pick, but it's all preset. So this is an example of each anatomical site that we have and that we, so we have a Siemens, like I said, Healthineers. So you can see here, like the first one is head and all the protocols that are set for head. Then this is like thorax, all the protocols that are set for thorax. This is for abdomen, pelvis, and then extremities. But you can see what it is, you pre-select it. You can even change the patient orientation. So right now they're oriented head first. You can change it so that the patient be feet first, or that you can then also reorientate if the patient is not supine, we can orientate it to them being prone. The benefits of protocols is streamline the scanning process for the RT to get better image quality, and then of course, allow a limited patient dose. That's how come we're able to do our SIMs within an hour, and that's with patient coming in, doing the scan, doing the paperwork, and getting them an appointment time. Everything can be done within that hour that we allot. The physicians will indicate the desired protocol on a stimulation request, or your facility can decide to have default protocols that will be used per anatomical sites. So here, I think this is my video. So this is a video of us scanning and what it looked like. So I'm just gonna play it and then I will answer questions if we have any questions about this video.
Marissa, would you like to tell us the advantages that you think for this particular case, adding IV contrast supported?
Yes, so I wanted them to see the video, so if you had questions, I will talk to all of it. So this case was an esophageal, and it was the anterior aspect. I mean, the superior aspects of it. So if you notice, he had a mask because they, hold on, let me pause. Over here. So you saw that we started scanning from the top of his head all the way to like mid thorax. And as we went through, let me see if I can. You can see here where the lymph nodes, everything's highlighted here, more there. Here you can see the BBs, because that's where the ISO was. More soft tissue that's being highlighted. Now we're into his lungs. I think they just want to go all the way down. And it was done mainly for treatment planning. It makes it easier to create a plan. They can see what lymph nodes are involved. They can then see it a lot better. If not, everything's going to look gray, right? You won't be able to differentiate between anything on the inside. Everything will have this gray matter. Only thing that's going to highlight white will be bone. So it makes it easier for the doctors when they're drawing out their contours. It makes it easier. Our doctors and our residents draw contours. It'll just make the process easier. They know exactly where they're treating, and they can create a better plan. Were there any other questions relating to the scan I have provided?
I think this offers a great opportunity to wrap up quite a few questions that had come through. And the main areas are changes in anatomy from the time a mask for a head and neck setup was done to the time that the treatment starts. So often patients might be on steroids, they have gained weight or lose weight, and the mask doesn't fit as well. What do you recommend in those situations? That's the first area. Second area is how to deal with the changing densities that IV contrast or PO contrast can introduce in the planning of radiation.
So most of our, let me backtrack. A lot of our patients that we do treat a lot of head and neck. We have a TrueBeam and we have a Tomo unit. So we do a lot of CBCTs. So we could definitely see the change in body tissue. So when we see there's a rapid weight loss, we will rescan. Generally for our head and neck patients, we rescan at 15 fractions just to see what's going on. But if we see that the setup is not working and the patient has lost a significant amount of weight, we will replan and we'll rescan and then replan. And then what was the other question? I'm sorry.
So yeah, whether or not you use chimp to kind of give you some wiggle room in how tight the mask is and what does it, because I don't think everyone is familiar with that particular application.
Well, yes and no. It depends on the type of aquaplast mask you have and what mask you use. Our old system, yes, we could put a shim in there and it would give us a little bit of wiggle room. Our new masking system, we do not have shims for that. What we have been doing instead is we know many of our head and neck patients are going to lose weight, so it's going to happen. We've also learned that for the mask to work a little bit better, we try to keep them on longer, even though once it's dried, we would, instead of taking it off right away, we may keep them on maybe another 2 or 3 minutes to ensure it doesn't shrink too fast. That's another technique, so it won't get so tight when we start to use it. I have some diagrams in here. I didn't realize I talked too much. I'm sorry. That shows some of our setups, and you can see it from our masking system. This one clips in, but there is a little bit of wiggle room within the masking, not a lot, but they set up amazingly well. Were there any other questions? Because I can show some diagrams.
Yeah, if you want to expand a little bit of what a sham is and how to be used.
Well, a shim will be like a little, like a U-shaped piece of plastic. I don't think I took a picture of a shim. That will be, if you look here in this mask, there's like little prongs. I'm trying to show you here. And you would put the shim on top of that prong. So when you put the mask on top, it'll give you maybe like not maybe a millimeter of space, but that millimeter will make a big difference when the mask is super tight. This is our SRS masking system, which comes with a shim in place. So there are these buttons right here that we can use that would automatically move it like 1 millimeter to give the patient a little bit more space. Let me see. Trying to see if I took a picture of a shim. I took pictures of different masking systems, but I don't think I took a picture of a shim. No. I have some pictures of different setups that we could review real quick. I know I went over my hour. I'm so sorry. But just different mobilization devices that we have. If you want to treat the thorax, some ideas, you can use a wing board and a vac lock or alpha cradle underneath. This is with the alpha cradle and the wing board. This is if you want to do a large SBRT. We have these large molds that we use. I have another picture of like head and neck, all the instructions we have with all our pictures, what we're supposed to do. Like you can see from it where to set up, the patient cannot have any dentures in. We would have a face photo. I took it out for patient privacy. Same thing with our breast patients, how we use a supine board and setup instructions, from breast board, setup instructions for these. And, abdomen. Pelvis. As you can see, it said patient comes in wheelchair, so we knew that we need to pick up the patient, a patient prone on a belly board, and then extremities. We try to make like an alpha cradle or a vac lock for an extremity to ensure that since you have to biangulate. Setup instructions. Again, this man had 2 sites, I believe. And just some tips and tricks of the trade. I just wanted to go over this, and then that should end my my little talk here. Sorry. So some tips and tricks I've learned over the time. If patients are claustrophobic or in a lot of pain, pre-medicate. Make sure that they're comfortable before they'll start, and make everything so much easier. Patient is in a comfortable position, they'll be less likely to move during treatment, and treatment will be a lot faster and more reproducible. Straighten the whole patient, not just the treatment site. So I've seen patients where the head is one way, the thorax is straight, but then their pelvis is another way. No, make sure the entire body is straight. No jewelry, no extra clothing, blankets, cushions. Make sure that they just have on them what they were simmed. And make sure having skin folds in the treatment area, especially for belly, breast, and head and neck patients. Key points to remember: a good setup is important for a good treatment plan and for good treatment delivery. Thoroughly document everything. Communicate everything to the treatment planning and physics team. And attention to detail when doing a CT scan will help to obtain a good scan and treatment plan. That ends my talk. Do you have any other questions or concerns?
Oh, this was great, Marissa. Thank you so much. Very, very useful, practical concepts. some of them not as clear or not as familiar with some of the participants, which is great because we get to learn what areas they needed to get more explanations and a little bit more details. And this basically opens up a whole constellation of questions because this is basically the art of radiation oncology, how you set up patients, make it reproducible, making it in a way that you can deliver treatment safely. And you covered a lot of ground in many of those topics. I do have, I believe, a couple of outstanding questions.
Okay.
Let's start with the one that it seems to be very much one of the points you address in the lecture, perhaps just to repeat that, and is what options do we have when patients cannot or are unable or unwilling to get tattoos? What options you have? I know you covered that, but perhaps just repeat
Okay.
it.
Definitely. There's a lot of options we have. One that we use a lot, especially with our pediatric cases, and is paint marker. It's like heavier than a Sharpie. It's kind of like oily. We will mark the site and then we'll put like a clear Band-Aid or Tegaderm over that site. And then we may have to image daily to ensure, but as soon as I see the mark starting to lift, I will remark it and put Tegaderm on it. I mean, that's what we use here in the United States. I'm sure there's other, something very analogous in your country that would work the same. Or we've used in the past, like a mole or freckle that was close to the ISO center if the patient didn't want tattoos, and said,
Sorry, Marissa, I muted you just to decrease the background noise.
so I said, depending what you have in your country, you can use paint marker, you could put Tegaderm, sometimes, and every day, or as soon as I started, like it started to fade or like that Tegaderm was lifting, I would apply a new one. Or we've used like a mold that was really close to a treatment site and said, you know, use this mold and go like 3 cm soup, that's ISO. I mean, we've also done that. Sometimes you have to be clever and creative to figure out what will work best for the patient. Is there any other questions?
I think just to go back to one that created a lot of downstream questions. How do you account for IV contrast, PO contrast at the time of planning? Do you have to override that density at the time of planning? And what general concepts can you introduce? Because I think that's a whole planning question, but there were many questions about that, how to account for the IV contrast, PO contrast for the planning process.
What do you mean account for, like when do I give it, or when they're actually creating the actual treatment plan, how do they account for it?
Correct. Given it's going to show us a different electron density and the impact the planning process itself, how do you account for that? That's basically.
Okay, I'll answer it this way. I'm not a planner, so I would have to ask the physicists how they account for it. I know our doctors like to use it as a way to highlight what they want to treat. I'm pretty sure there is a way to account for it. When I go to work on Monday, I can definitely ask the physicist, and he can give me that answer. But since I do not plan, I wouldn't be able to answer how they account for that density.
No, that's perfectly fine. And that's sort of what some of the participants provided information, at least as a radiation oncologist myself. I do know that the scope of this particular lecture is how to use it to promote good quality for the simulations and general concepts. So the specifics of when it's important and how to account for IV contrast in the planning process, a little bit outside the scope of this, but enough to say that yes, it could be countered and it can be overriding by making it water density, because it could be perceived by the planning system as something that it has higher density than actually is going to have at the time of treatment. So the basic answer is yes, it can be countered and it could be make it equivalent to water to account for the normal density of the body. And that way it can be accounted for at the time of the planning. But yeah, that was kind of to wrap up that particular part of the question, because it was yeah, it's very much a little bit outside the scope of this particular lecture. No, I think that covers most of the questions. Forgive me if I'm forgetting anyone specifically that we have not addressed. Feel free to send us an email, and I'm going to provide right now the email for other questions that we didn't have the chance to cover today, or other questions that come up as you're reviewing this material, the recording that's going to be available for you.